This is NSG3009, test number 2, chapters 12 through 16 study guide. First question, know characteristics of the epidermis, dermis, and subcutaneous tissue. The epidermis is thin, but it's tough. Its cells are bound tightly together into sheets to form like a protective barrier. The inner basal cell layer forms new skin cells. You need to know that the epidermis is completely replaced like every month or so, every 4 weeks. The dermis is the inner supportive layer consisting mostly of connective tissue or collagen. This is tough, fibrous protein that enables the skin to resist tearing. It also has that elastic tissue that allows the skin to stretch with body movements. It also contains the nerves or the sensory receptors and blood vessels and lymphatics lie in the dermis. The subcutaneous layer of the skin is mostly adipose tissue, which is made up of lobules of fat cells. Epidermis tissue stores fat for energy and provides insulation for temperature control and protection by it's like got a soft kind of cushioning effect. Question number 2, what glands are responsible for diaphoresis, which is sweating? There are 2 types of basic sweat glands. That's the eccrine glands, E-C-C-R-I-N-E, and they are coiled tubules that open directly into the skin surfaces and produce a dilute saline solution called sweat. Know the characteristics of an elderly individual's skin. That's important because elderly people, there's just like a accumulation of factors that take place when for an aging person, and that puts them at risk for skin disease as well as breakdown. So basically they have thinning of the skin, a decrease in vascularity and nutrients. They also have the loss of protective cushioning of the subcutaneous layer, as well as, you have to take into consideration that being elderly, you have a lifetime of environmental trauma to the skin. So that as well as just the social changes of aging, them having an increasingly sedentary lifestyle, and also the chance of immobility as well causes more of a risk for people that are elderly. Terminology for excessive dryness of the skin. There are a lot of little different things that go on with the skin, but excessive dryness is called xerosis, X-E-R-O-S-I-S. That is, when you hear somebody say xerosis, is the term used to describe skin that is excessively dry. Then you may hear other terms like pruritus, which mean a person has excessive itching. of course, you know, alopecia, meaning refers to hair loss. And then the opposite of xerosis, which is dryness of the skin, is called seborrhea. And seborrhea refers to oily skin. You can look that up on page 203. No, let me see what is next. No, the causes of acne. The main cause of acne or increased sebum production and epithelial cells that does not desquamate normally. So increased sebum production and epithelial cells that do not desquamate normally is the main reason that people tend to get acne. Approximately like 90% of males and about 80% of females develop acne. Usually when a person has take various types of drugs, they may increase sunlight sensitivity, and they also may give a burn response. I wanted to throw that in there. Usually sulfonamides, drugs which, you know, a person may have when they have diabetes, thiazide diuretics, oral hypoglycemic agents, and tetracycline, or those type of drugs that affect a person. Usually you need to tell the individual that they need to take care of their skin, you know, about the importance of sunscreen and avoiding direct sunlight as well. Knowing the danger signs for pigmented lesions. We have to talk about, or they have the mnemonic, the ABCD. So ABCD, we talked about that in class. Asymmetry, which means it's not symmetrical, which is the A. Border irregularity, which is the B. Color variation, and then any type of diameter that is greater than 6 millimeters would be abnormal characteristics when a person has a skin lesion. So always remember that ABC, D, which is that asymmetry, border irregularity, color variation, and then if the diameter is greater than 6 millimeters. You can refer to page 208 in your text if you want to read up a little bit more on that. Know the characteristics of a person that potentially may go into shock. When a person is going into shock, they usually say their skin looks like pallor. Pallor is like just that really, really pale look that they have because you have a decrease of tissue perfusion, you know, or can I say blood flowing to that level, and vasoconstriction. Usually in dark or blacker skinned people, the skin appear more ashen gray or dull, you know, like in appearance when a person is going through some type of shock. Know how a person with COPD or emphysema, skin and nails would present. So as we check, we're looking for things like clubbing of the nails, when a person has some type of congenital heart disease, or any type of neoplastic, which is like a cancer or pulmonary disease. You'll see that clubbing of the nails. So usually when a person has COPD and you don't have the correct tissue perfusion and stuff to feed the nails, you'll have that clubbing look. If you refer to 213, you'll see where it looked like the nail is kind of clubbing. It's kind of rolling like upward. You know, it sits upwards. Let me see. Usually like a normal type of nail is like firm at its base, and the angle is like at 160s. And then when you have like a clubbing, if you're looking at the page, like I told you earlier, when you have clubbing, it's the angle straightens to 180 degrees or greater, and then the nail base, it feels more like spongy, you know, or it's more spongier. Okay, let me see. If a person has like a real terrible itch, what might you find upon examination? So like if a person has a terrible itch and you know that a person, if they have a terrible itch, they're going to be constantly scratching. And the correct name for that is called lichenification. 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 Look on page 232. It's called lichenification, and that comes as a direct result of a person having a prolonged itch, and it comes from intense scratching. So what it usually do is it thickens the skin area after a while, and it produces like tightly packed sets of what they call papules. There are also other little things that a person can find in someone's skin, like for instance, like if you've ever heard of a keloid. A keloid is what they call a hypertrophic scar, and whenever you hear hypertrophic, that means that that's a scar that grows, you know, and it gets thick and it sits up. A lot of times people of African American descent tend to keloid more. A fissure on the skin is like a linear crack with abrupt edges around it, and it also it extends all the way into the dermis, and it can be dry or it can be moist. Keratosis is also something else that can be on the skin. It's a lesion that are raised, and it has like thickened areas of pigmentation that appear crusted, scaly, or kind of like warty looking. Okay, so those are some things that you can look and observe when you talk about Non-symmetry of palpebral fissures is indicative of problems with which cranial nerves. Basically, facial muscles, or basically, if you don't have symmetry, cranial nerve 7. So if you have asymmetry of palpebral fissures, it may be attributed to damage to cranial nerve 7. And a lot of times when you look at cranial nerve 7, and when I say palpebral fissures, just like the lines that are the normal kind of like indentations or whatever, or like when a person has a smile and you're seeing that asymmetry, you know, a lot of times you may look at that and you may say to yourself, oh, okay, well, what is that? And that may be as a result or attributed to the damage of cranial nerve 7. And a lot of times a person will look at that and they may say, what is that? And then you may want to attribute it to something called Bell's palsy, which results as damage to cranial nerve 7. Let me see. Okay, so as you'll check, and you'll check for like senses and that type of thing, and you'll ask a person, okay, assess sharp, dull, stimulation, sharp, dull. And a lot of times that's how you assess whether or not a person has can even differentiate between like sticking somebody, if it's sharp or dull. That is your cranial nerve 5. So I said earlier, cranial nerve 7, like if a person smile or something like that, that's 7, and that's contributed to a disease process called Bell's palsy, or damage of cranial nerve 7. But the actual sensation of pain or touch is usually by cranial nerve 5. Cranial nerve 5 is what they call the trigeminal nerve. Okay, cranial nerve 5, the trigeminal nerve, is the sensation nerve. So if you try to poke somebody and they can't distinguish between, oh, if this is sharp, if this is dull, that's associated with cranial nerve 5. Okay, the 2 pairs of salivary glands, which are accessible by examination on the face, or the parotid glands, which are in the cheeks over the mandible. It's anterior to and below the ear. So the parotid glands and the submandibular glands, which are beneath the mandible at the angle of the jaw. So those are the 2 pairs of glands, or salivary glands. Usually the parotid glands are non-palpable, where you can't necessarily palpate them, but the two pairs of glands, if you know, had to like say which ones are the, or associated with salivary, that would be the parotid and submandibular. Parotid and submandibular glands. So you should be able to pick those out. You've been palpating those glands when you check, like for the lymph nodes. Okay. You also have various glands, like for instance, you have the thyroid gland. The thyroid gland can be a very, very dangerous, highly vascular endocrine gland. And when you see elevated levels of T4, T3, and that type of thing, those are the hormones and stuff that are excreted by the thyroid gland. So whenever you see a T4 or T3, and if someone was to ask you where did that come from, know that it comes from the thyroid gland, just the thyroid. Okay. Know the characteristics of a cancerous and benign nodule under the thyroid gland. If you see a nodule and the nodule is it grows real rapid, generally, and a lot of times people even say through the neck, when, like, if you're pronounced, like for instance, if you're assessing the thyroid, usually like painless, rapidly growing, that type of, that's the type that may be cancerous. Especially if it's like a single nodule and it's in like a young person. However, like if you see a cancerous nodule, even though it may be rapid growing, maybe it may not be necessarily painful, know that another characteristic of a cancerous nodule is they tend to be hard and they tend to be fixed. So they're not mobile. You can't kind of move them around like a little lipoma, a fatty nodule or something like that. No, they're normally fixed and hardly fixed to surrounding structures, and they're usually not mobile. So know that is the main characteristics. They're rapidly growing, they're usually hard. A lot of times they may not be painless. A lot of times, especially in younger people, it may be just one little nodule, so know that that's like a main characteristic of cancer. Hard, fixed to the tissue around it. It's not mobile. A lot of times it may not be necessarily tender. It's rapidly growing, that type of thing like that. That's the main characteristic Let me see. Lymph nodes are accessible for examinations in which areas? Let me roll that up. Okay, lymph nodes are accessible for examination in lot of which oh, I know what they're getting at in which areas. Okay, the best areas to examine the main 4 areas where lymph nodes are more accessible for a nurse to examine would usually be head area, neck, arms. Oh, I'm sorry, head and neck. So we'll say head and neck is the main area. The arms, the inguinal area, and the axilla. So if you want to accessibly examine the lymph nodes, they're more accessible in the head and neck area, the arms, the inguinal area, and the axilla. Those are the main 4 areas where lymph nodes are more accessible. Okay, the nurse needs to make sure that when, you know, like you're just totally like, I'm gonna examine for lymph nodes, that you're examining mainly in those areas. Okay, know how to palpate neck lymph nodes properly. I think we already talked about that. Y'all have been doing that in lab. Let me see. Okay, so know the symptoms of a head injury, cluster headache, migraine headache, and meningeal inflammation. Basically, I wanted you to know that a cluster headache is usually unilateral, so it's usually on one side. Migraine is commonly one-sided, but it can be on both sides, and it's throbbing and pulsating, and it usually is behind the eyes and the temples or at the forehead. A meningeal inflammation is usually accompanied with a temperature, a high fever, as well as a stiff neck. That's basically what I wanted y'all to know about the difference. I do know about that because I've had meningitis before as well, and I've treated a lot of people with that. Usually when a person has a head injury, it's usually accompanied by a lot of edema as well, and the pain and stuff is located at the point of injury. Okay, so know where to palpate the, temporal mandibular joint for crepitation. The temporal mandibular joint is just below the temporal artery, And so it's basically just anterior to the ear, to the trachea. So that's the best way I could tell you as far as that. So it's just anterior to the trachea, at the temporal artery. That's where you would check for the temporal mandibular joint. A lot of times people are looking for like TMJ when they're looking for that as well. Let me see. Be able to describe the different, know the specific signs of acromegaly. We've already told you about acromegaly in the other class, but I will repeat it. It's excessive growth, secretion of growth hormone. And what that does is it just creates an enlarged skull and thickened cranial bones. So patients will have like elongated heads. Their faces will look kind of massive, and they'll have prominent noses and lower jaws and heavy eyebrow ridges and just really kind of coarse facial features. You know, that's basically what you'll see when you're seeing that type of abnormality. Be able to describe the difference between the face with Bell's palsy and CBA. Like I told you, a lot of times people have a paralysis when they have a CBA, a lower facial muscles, but the upper half of the face will not be affected, on to the intact nerve from the unaffected hemisphere. So the person may be still able to wrinkle the forehead and close their eyes and that type of thing. Where when you have somebody, for instance, and they have Bell's palsy, is just like that whole side, you know, like they're not able generally to raise their eyebrow or whistle or that type of thing like that. But because it's just going to be it's like the whole nerve, where with the CBA it's due to a lesion. So a lot of times it can actually correct itself even better. And so whatever unaffected area that hemisphere is, you know, directly involved, it will not affect. So a person could actually have a CBA and be able to wrinkle their forehead or close their eyes or something like that, where basically it's like the nerve, the actual seventh cranial nerve is affected with Bell's palsy. Okay, know the characteristics of a tracheal shift. The trachea is pushed usually to the unaffected side. Like for instance, if a person has a tumor or an enlargement of the thyroid, or even if they have what they call a pneumothorax, the trachea is pushed, you know, past that unaffected side. So basically that's what the characteristic is. So that's how you could tell if a person has what they consider a tracheal shift. So always remember, because like when you have things like a person has, for instance, a large, like if they have atelectasis, or something like that, where their lungs collapse. The trachea, trying to get air, may be pulled to the affected side, you know. And a tracheal tug is like a downward pull. And that usually occurs when a person has like an aortic aneurysm or such. So just know that a tracheal shift is the trachea being pushed to the unaffected side. Let me see how to assess. Oh, okay, so then you're assessing the head, because we still on the head. And basically, all I need you to know about the head when you assess it, for instance, infant. Okay, so when you're assessing the infant head, you know how they have the fontanel, and we usually call that as like the soft spot at the top of an infant's head. If the fontanel or the soft spot at the top of an infant's head is sunk in, that will tell you that that infant is dehydrated. If the baby head is like bulging at the top, that means that the baby might have increase in the cranial pressure. So that could come from them having hydrocephalus or having increased fluid, you know, built up in their brain. So depressed means they dehydrated, and increase in the cranial pressures mean that it will be you know, bulging. Know how to palpate when I say lymph nodes properly. All I wanted you to basically know is most lymph nodes are generally non-palpable in adults. And as an adult gets older, the ability to palpate lymph nodes decreases. Normal lymph nodes are usually movable, discrete, soft, and they're usually non-tender. Using gentle pressure is usually recommended, because when you use gentle pressure, it's better, because like if you use strong pressure when you palpating the lymph nodes, you're actually pushing the nodes into the neck. And usually you need to palpate with both hands so that you can symmetrically compare the size of the two sides to make sure that it seems like it's normal, you know. So that would be the best way to palpate, you know, lymph nodes. What is responsible for movement of the extraocular muscles, like you heard us say EOM, and basically the cranial nerves 3, cranial nerves 4, and the cranial nerve 6 are responsible for the EOM 3, 4, and 6. If you like really need to review like as far as the cranial nerves, you can look, you know, it's like a chart on page 283. I think it's 283 in your book. Okay, so oculomotor, which is 3, the trochlear, which is 4, and then cranial, let me see. I don't want to tell you the wrong thing. Cranial nerve 3, which is the oculomotor. Cranial nerve 4. Yeah, 4, which is the trochlear. And then cranial nerve 6, which is the abducens nerve. So when you talk about, you know, when you do those 3, when you do the 6 fields and you have the person look and you just checking for basically their ability to move those muscles. Like when you tell them, don't move your head, you're using the 3, oculomotor, the 4, which is the trochlear, and I'm thinking in order. Okay, and then the 6, the abducens nerve. So those are the main nerves that are checking your EOM. Okay. Let me see. Stimulation of the sympathetic branch of the autonomic nervous system would affect the eyes. How? Sympathetic nerve dilates the pupils and elevates the eyelids. Sympathetic, parasympathetic nervous system stimulation causes the pupils to constrict. So know that stimulation of the sympathetic branch of the so you want to think about that, y'all. Sympathetic dilate and elevates the eyelid, and then basically you're closing and constricting with the parasympathetic. Okay. Know the physiologic changes when a person has presbyopia. Presbyopia is basically when your eyes cannot accommodate for near vision. Okay, a lot of us, as we get older, suffer from presbyopia, and you'll see like older people sometimes holding something back away from them instead of having it too close. And that's basically because like the lens tends to lose elasticity, and it just with the lens losing elasticity, it decreases its ability to change the shape to accommodate for near vision. So that's the result. That's why you'll see it in presbyopia. So that's what the condition is called, presbyopia, where the lens loses elasticity and it decreases its ability to change the shape, and as a result, you don't accommodate as well for near vision. Okay. Know the difference in the eyes of various ethnic group. Oh, so I mean, basically, if you're ethnically based, in the color of the iris, you'll probably see more retinal pigmentation, and they'll have darker retinas basically behind them. So that's all that's saying. You know, when you think about pigmentation and people having the ability to see and that kind of thing, and having color or being I guess you could say darker. Basically, the retina or the background, they say, is usually darker. That's the only thing. That's the difference. Let me see. No. A visual acuity. How well can you see? What test are we doing for visual acuity? We doing the Snelling. So the Snelling is the most accurate measure of visual acuity. So know that. Know that the Snelling is for visual acuity, just like you know the confrontation test is for peripheral. Even though we've been using the Jaeger card or what they call newspaper tests or the little card, they usually use that to test near vision, but we've been just kind of using it as our measure of our Snelling chart. But just know that if anybody ever asks you about, you're checking how well somebody could see, and that's what visual acuity is. You're mostly using you're using the Snelling chart for that. Know how to read the Snelling chart. So when you read it and you see somebody and they have 20/30, or they have 20/20 or 20/40, know what it means. So the number that you're gonna see, that 20 at the very top of that number means how far you standing from the chart. So you're standing 20 feet. So it's always going to be 20. It's always going to be 20. Okay? So that top number indicates the distance the person is standing from the chart. Okay. So that lower number, or that denominator, it gives the distance at which a normal eye can see. So a normal eye, that denominator gives the distance at which a normal eye can see. So know that the top is how far you're standing from the chart, and then the denominator, or the low number, is the distance at which a normal eye can see. Okay. And that's the definition. Know the proper technique for pupillary light reflex. As I was showing people when we was even doing it in lab, I always told people that you always come advance the light in from the side and note the direct and consensual pupillary constriction. So you're always going to come from the side, and then you're going to note the direct consensual pupillary constriction. Okay? Know how to assess accommodation. When you assess for accommodation, it's basically it's pupillary constriction, and it's like, how can I say, convergence kind of the axis of the eyes. So accommodation is pupillary constriction as well, but it's related to the convergence of the axis of the eyes. It's not related to like the light. So that's kind of like what the difference is between pupillary light reflex, because you're doing it, it's consensual, it's the direct consensual pupillary constriction, and it's totally related to the light, where the accommodation has to do with like the pupils looking and they're converging, you know, so they'll constrict and dilate. Constrict when you're pulling them in. The closer that object or that hand or whatever gets to your eyes. So the accommodation reaction includes pupillary constriction and convergence of the axis of the eyes. So that's basically the right way to say. That red glow in the eyes when you examine with an ophthalmoscope, which I wanted some people to come to the lab tomorrow and just take a look at that. That red glow in the eyes is called the red pupil red reflex. And all it is just normal, and it's basically a reflection of the ophthalmoscope light off the inner retina. That's all that light, the red reflex is. When you examine the retina with the ophthalmoscope, let me tell you how it's supposed to look. You're supposed to see the optic disc, and the optic disc would be like next to the nose side. It's like a creamy, yellowy, orange, like a orangey, almost creamy, orangey, yellow, pink color, almost like a, what you call those, dreamsicle, and the edges are distinct, and they're, you can see the edges of that optic disc. It's not blurry, it's like real distinct. That's basically when you look with the ophthalmoscope, and it's located on the inside right next to the retina, and it's like that creamy yellow area that you see when you look with the ophthalmoscope, the optic disc. Because when you look in your eyes, you'll see like this big orange circle, and then you'll see like the arteries and the veins. The veins, the way that you can tell the difference between the artery and the veins is that the veins are usually thicker than the artery. And so you'll see like that optic disc, and it's like real, it's like, okay, I'll put it to you like this. You'll see the orange, you'll see these veins going through it, cause you, and the veins will be prominent, and you'll see the thick ones of the vein, and then you'll see some lighter lines, and they'll look like arteries. And then you'll see this yellow kind of light, round yellow light within that area, and it's the closer one by the nose, and that is the optic disc, and it'll be real prominent. You can't miss it. Then on the other side, away from the nose, you'll see the macula, and the macula just looks like almost like a little bit darker, a darker kind of pigmented area, you know, and it's round as well. So that's how it basically looks. Let me see. Oh, know the signs of retinal detachment, which is really serious. Basically, the person has shadows or diminished vision in like either half or a quarter or so of their visual field. That's what they usually have when they have retinal detachment. It'll look like they have like half of, like, so if somebody comes in and they tell you that I can only, okay, I got knocked in the eye and I can only see like half. It's almost like half my vision is gone. Well, then that is usually within their visual field that may be that their retina is detached. Yeah, that it's pretty that's pretty serious. Okay. Macular degeneration. Macular degeneration is usually probably about the most common cause of blindness in a person, and it's characterized by people having like loss of central vision. So basically macular degeneration, a lot of times it may be age related, and they'll have yellow deposits and less vascularity, you know, like blood flow and stuff going to their eyes. And usually they say women tend to have that more. And what it does is it makes it really hard for a person to read books or papers and do fine type stuff. Like, for instance, they used to sew, and it's hard for them to put the thread through the needle or read real good. And that's usually, a lot of times they say that just comes with time. And usually their peripheral vision is not. So it's usually their central vision that's affected when they have that. There's a lot of different types of things that people have. Like, y'all know what cataracts are. Y'all know, and a lot of times that come with age as well. You have cataracts, and that's when their lenses are opaque, and that's just like an opaque build up, and after a long time, a lot of times they'll get it removed, and oh my God, they say that it happens, that a lot of people, older people, say that it improves their visions like significantly. Sometimes people get chronic open angle glaucoma over a while, and it involves a gradual loss of them having peripheral vision, being able to see on the side. And a lot of times this type of stuff is considered more normal findings or consistent when a person has problems with their age. So I just kind of wanted y'all to know the difference between like what you see when you see retinal detachment, and a lot of times that's from some type of injury. And I told y'all that they'll have that half where they can't see, and then macular degeneration, central vision, cataracts, that opacity, or like where a lot of times you can even see it on top of their pupils when you're looking, you know, and then chronic open angle glaucoma, where they lose most of their peripheral vision. Okay, let's see. Know the names and parts of the outer and inner ear. I just want y'all to be just know what consists of the inner ear and what consists of the outer ear. And if y'all know like what the difference is between the inner ear and the outer ear, basically you should be fine. Like, you got the auricle and the pinna and the external. You got the external auditory canal. uh, uh, which the external auditory canal really consists of the eardrum and tympanic membrane. Then if you know anything about the middle ear, you got the eustachian tube and that type of thing. The inner ear, you got the vestibule. Remember we talked about the balance and the cochlea and the bony labyrinth. If you pretty much know those parts of the ear, you should probably do pretty fine. You could find those on 326. So if you just know how they look and you know what it is, you should do pretty good on there. Okay, we already know what cerumen is. We've talked about that. Because in the inside of your ear you have glands and they secrete cerumen. And cerumen is yellow waxy material. And the whole purpose of cerumen is to lubricate and protect the ear. Let me see. No, the things that made, let me see. Did I? No. Oh, why would a 2 or 3-year-old have 3 ear infections in 1 year? I'm gonna tell you the reason why infants tend to get more ear infections is because their eustachian tube is shorter and wider than an adult. And so therefore, with it being more horizontal because it haven't migrated yet, pathogens from the nose and stuff like that usually can migrate to the middle ear better. So that's the reason why an infant will get, infections, and then once you see them and they get older and stuff, that type of stuff goes away once they grow into it. We already know about the, let me see, proper technique to use the otoscope. Basically, we're talking about when I say proper technique to use the otoscope, when you looking in a person's ear with an otoscope, how do you move the pinna? So, like, remember we was telling you, I told y'all in lecture, and I'm sure like when I was helping some people, I just kind of mentioned it in lab as well when we was doing checkoffs, and I was telling you guys to pull the pinna up and back. If it's an adult, right? Or an older child. But if it's a young child and stuff, remember we talked about moving the pinna down. So basically, just knowing the positioning is important. Okay, now remember when for the hearing we do the voice test, or what we call the whisper test. Okay, so with you being about approximately 2 feet from the patient's ear, you whisper a set of numbers and letters and stuff. That's basically how you do it. And you don't have to have the patient occlude their ear. You don't stand too far. You really want to be about, no more than 2 feet from them when you do it. And you just whisper it. You say it in a whisper sound. Oh, let me see. Oh, a buzzing sound in the person's ear. If a person has a buzzing sound, that could mean that they have tinnitus. And that depends on, I mean, tinnitus can really truthfully accompany like all kind of, I mean, there's like several disorders when a person has tinnitus. They call that the phantom sound. They can have it if they have like a lot of cerumen in their ear impacted, if they have a middle ear infection, if they have oh God, I can't think of the name of the disease process. It begins with M. If I think about it, like it goes, they have a lot of times they have vertigo with the disease. It begins with an M. Meniere's disease. Okay. If a person has some type of allergy or reaction to some type of aminoglycosides or amikacin or some type of myosin, like I told you, furosemide, certain different things like that can cause tinnitus. It's for inflammation in the person's ear. Know things that may affect a person's ability to smell, a person's ability to smell, well, basically, the sense of smell can be reduced because of a person may be having a decreased number of olfactory nerve fibers. So, like especially when a person, especially as they get a little bit older, a person can have a decreased number of nerve fibers, and as a result, that could decrease the amount of how a person has a sense of smell. Okay, I'm back. I'm sorry, my son just walked in. But as a result of a person having decreased ability to identify a decreased number of nerve fibers, as a result, they tend to have a decreased ability to identify odors as a result. So that a lot of times that happens as people tend to age. Okay. Know the anatomy of the nose. I think pretty much everybody should be pretty good as far as knowing like, you know, the parts and stuff of the nose. I'm not trying to get into a lot of anatomy and physiology, but I would say be familiar like the lateral walls of the nasal cavity, the bony projections, the superior, middle, and inferior turbinates, that type of thing like that. And just know what the septum, know just the real basic areas of the nose. So like for instance, if I ask you what areas increases the surface area of the nasal cavity, I want you to be able to tell me what those areas are that increase the surface area of the look on page 353 and you'll be able to find the answer to that. I forgot, I didn't know, I missed question number 42 when I asked. It says, why does one have ciliated mucus in and cilia is basically, you guys, like the hair and stuff. And basically all that hair does is just filter and move out excess matter, coarse matter from whatever inhaled air. So basically that's all they do, is they act as filters. And they tend to help warm the inhaled air as well, but the main part is filtering. So keeping dust and bacteria out of your nose. Okay. Know the proper look of the tonsils and be able to grade the tonsils. Tonsils are the same color as the surrounding mucous membrane, or they look more granular and their surface show deep crypts. Tonsillar tissues enlarges during childhood into puberty, and then they use the involute, which means they go down some. So they usually, or they look a lot as far as the same color. So if you see somewhere and they look involuted, and which means that they look granular, and they have deep crypts, that really isn't a problem because that's the way they're supposed to look. Know the variations of nose, mouth, and ears. Oh, we already know about how to grade the tonsils. I went into that. The 1 through 4, remember? And a lot of times, if it's anything larger than a 2, that means a 2 or larger, that means a lot of times the tonsils are inflamed. Okay. How do you know the variations of a nose, mouth, and ears in an elderly person? We already talked about that. The sense of smell may be reduced. Nasal hairs may grow coarser and stiffer with aging. The gums may recede with aging. And the saliva usually decreases. So I want y'all to be aware of that because that is a question. Sense of smell in an adult reduces because we got a decreased number of olfactory nerves. Nasal hairs, though, usually grow coarser. And the gums may recede. So they don't hypertrophy, they hypotrophy. They get littler. And then the saliva, the amount of saliva is usually decreases. Its best way to stop frequent nosebleeds is the person should sit up with his head tilted forward and pinch the nose between the thumb and forefinger for 5 to 15 minutes. Usually a lot of people think that they should go backwards, but actually it's just the opposite. Be able to assess dehydration in the oral cavity. Dry mouth occurs with dehydration, and usually the tongue has deep vertical fissures, which means they have these deep vertical lines. So the mucosa is, of course, dry, and usually they have fissures, like you can see the lines, and they're usually deep when they're dehydrated. Usually, like if a person has an infection or something like that, they usually have bright red swollen tonsils, large white spots, and that's basically what it is. Let me see. When a person has, I wanted to explain to you guys too about ulcers and that type of thing, because I got some definitions I want y'all to know about. Like, for instance, candidiasis, which is a white cheesy curd-like patch on the buccal mucosa tongue. Have you ever seen where people had the white? It scrapes off, leaving the red surface that easily bleeds. It's almost like a yeast infection. And a lot of times a person will get that if they've been taking a lot of antibiotics where they kill up, you know, like the natural flora. And on a person that might be immunodepressed. If the person has a pustule on their mouth or something, or lip, a pustule is an elevated circumscribed lesion and is filled with turbid fluid pus. I want y'all to know a pustule is an elevated circumcised lesion filled with turbid fluid or pus. I told y'all about a hypertrophic scar, which is a keloid. A bulla, B-U-L-L-A, is pretty larger than, at least larger than 1 centimeter, and it contains clear fluid. And a papule is solid and elevated, but it measures less than 1 centimeter. So know the difference that a papule is little and is solid and elevated. A bulla is bigger than a centimeter, and it contains clear fluid. Pustule, it contains pus. Hypertrophic means growth. That's a keloid. I want y'all to know all the differences between those type of things. Let me see what else. I think I talked about presbycusis as far as hearing loss that occur with aging, and is found in 60% of the older than 65 years. It's a gradual sensory neural loss caused by nerve damage in the inner ear or auditory nerve, and it slowly progresses after the age of 50. The person first notices a high frequency tone loss. It's usually harder for them to hear consonants, and the ability to localize sound is impaired. For presbycusis, I want you to know all of those things. When it comes, it's ancestral neural. It's in the inner ear or auditory nerve. High frequency tone loss, hard to hear consonants, and the ability to localize sound is also impaired. What type of things diminishes the sense of smell? Cigarette smoking, a person with chronic allergies, and also aging. Those are the main things that affect the sense of smell. I think I got you as far as all the different lesions and things that I thought were important. So just listen to it a couple times and just read your book and you should be fine. Okay. Thank you.